Cancer Podcast. I'm your host, Miranda Weinberg with the Sina Matkowitz Foundation. And if you don't know about the foundation, we are a nonprofit that's committed to the awareness, prevention, and cure of pancreatic cancer. And I'm excited today because we are going to be talking to two radiation oncologists from the Medical College of Wisconsin. Today we have Dr. Beth Erickson and Dr. Bill Hall joining us. Thank you guys for being here.
Thanks for having us.
Yeah, it's a pleasure.
I'm really excited about our conversation today, but I do want to start off first by thanking our sponsors. Without you guys, we wouldn't be able to impact the lives that we are able to impact. So I think it would be great to get started just by talking about a little bit of your backgrounds, both of you, kind of how you started and how you got to the place you are today. So Dr. Erickson, would you like to start?
Sure. I'm a Wisconsin native. I grew up in the thumb of Wisconsin called Door County, a vacation spot, so to speak, and attended Marquette University and then the Medical College of Wisconsin, and was fortunate enough to come upon the field of radiation oncology through a summer externship. And I quickly became passionate about becoming a radiation oncologist and caring for cancer patients. I've been on faculty here at the Medical College ever since, so over 30 years, and have grown and evolved through these decades of change, and have been very, very happy to have a large proportion of my practice be pancreas cancer patients. So it's truly a pleasure to be here today, and happy to have my wonderful colleague, Dr. William Hall, and I'll let him introduce himself.
Thanks, Dr. Erickson. So my name is Bill Hall, and I'm also a radiation oncologist here at the Medical College of Wisconsin. I'm not originally from Wisconsin, although I've lived here for a very long time, and I sort of feel like a Wisconsinite now. I grew up in just north of the city of Boston, about 7 miles outside of the city. I also did my undergraduate at Marquette University, which is originally what brought me out to Wisconsin and has since kept me here. I was never intending on going to medical school, never really had an interest in becoming a physician. I studied biomedical engineering as an undergraduate and always planned on going into a career in physics or engineering or computer programming. And it wasn't until I began working in that career for a short period of time that I quickly decided that it wasn't a great fit for me, and I wanted to have more of a direct interaction with patients and really be on the front lines of healthcare a little bit more than I could be in the capacity as a biomedical engineer. So I quickly shifted gears and went to medical school. I went to Loyola University in Chicago, where I was very fortunate to be exposed to radiation oncology quite early in my training. And I really was captivated by it from the moment I heard about it, just the technological complexity of it, the really sophisticated combination of advanced biomedical imaging and advanced radiological techniques with very complicated physics and mechanics of delivering radiation through devices, and the novelty of it really captivated me. So, I started shadowing and becoming more and more interested in it as a third-year medical student. Subsequently did my residency at Emory University in Atlanta. So I was down there for about 5 years. And my wife and her family are from Milwaukee, and they always wanted to come back here. And so I joined the faculty here at the Medical College of Wisconsin after finishing residency. And I have been here ever since 2014. And it's just a wonderful place. I'm very, very happy to be here and have wonderful colleagues and feel very lucky. I primarily focus on gastrointestinal malignancies, very significant focus on pancreatic cancer. And I also do some genitourinary cancers as well. So prostate cancer and some bladder cancer also.
So interesting that it wasn't your initial field of choice, and then how life kind of brought you into this arena.
It is really, really interesting. Yeah. I mean, I love being a physician. I absolutely love it every single day. And I am so lucky. I think we're all very, very lucky to do what we do. And yeah, things happen for a reason. So I think it really worked out.
Or Dr. Erickson, I'm sorry. I read that you actually did some study in France. Did you?
Yeah. My other role in the department is the care of patients with gynecologic cancers. And I'm very passionate about part of that practice, which is called brachytherapy, which is placing radiation within and close to tumors. So when I was a resident, I had the opportunity to spend some time in France and learn from our French colleagues who are much ahead of us sometimes in techniques. And I was able to spend time there and then bring some of those facets back to our program here. And interestingly, the GI and GYN cancers actually go quite well together because much of what we do is image-guided radiation. We'll be talking about that later. But defining tumors with advanced imaging, sculpting radiation doses around them, in an effort to cure patients with cancers, many of which are inoperable. So those techniques that have been used in GYN cancers also fit very well within the GI scope of practice, and is really something that drives me forward. And Dr. Hall and I have been able to combine forces with Dr. Hall coming on board. I think having that partnership together just accelerates our practice and really broadens what we can offer patients who come to us. So it's truly been a wonderful partnership, and it continues.
Well, before we dive too deep, I think it would be important to start with maybe defining radiation therapy for patients that are recently diagnosed and families that are just kind of trying to wrap their mind around this diagnosis, if you'd like to start with that.
Sure. So radiation oncology is one of the three pillars of oncologic treatment. Of course, you have surgical oncologists, medical oncologists who deliver systemic therapies such as chemo or immune therapies. And then we as radiation oncologists who deliver radiation to cure cancer and to help in sometimes when we can't cure, to palliate cancer. And to become a radiation oncologist is a process. All of us, of course, attend a regular medical school after our undergraduate work. Typically, that's 4 years. And now the radiation oncology training is a 5-year program, including an internship year and then 4 years of residency. And during that time, you have lots of exposure, depending upon the training program that you attend and are accepted into, to see all the different cancers and their treatments. And there is some basic science knowledge. Of course, physics and radiobiology are kind of the foundation of what we do. But the clinical component of our specialty is much, much more than the basic science or the basic physics and radiobiology. And it's in that training process when you're a resident that you spend time one-on-one with faculty for rotations that are each 2 to 3 months, once or twice during that 4-year period. So it's rather like an apprenticeship where you gain the skills that you need by watching and by doing. And that includes seeing patients, new patients, follow-up patients, patients who are under treatment, learning how to plan radiation. Of course, we have a whole team of people that are working with us who actually create the radiation plans. And you learn how to take care of patients during radiation and long-term in follow-up, if there's recurrent disease or if there are complications. So it's its own defined specialty and very, very, I would say very strong residency program, actually one that's highly sought after now to get into.
Regarding the pancreas team and when you're recently diagnosed patient, where in the process of treatment do you come into the room? When would a patient meet with you?
Yeah, so patients typically meet with us a bit after their diagnosis. And this affords the opportunity for them to complete their staging workup. So that would include a biopsy, it would include CAT scans, sometimes PET scans or MRI scans, laboratory tests. Typically, the surgeons or the medical oncologists are the first to meet our patients. And then patients are referred to us at different intervals. Many times patients may start their treatment with chemotherapy, and then they might see us midway through chemotherapy or near the end of chemotherapy, knowing that radiation, at least here at MCW, is going to be before surgery. We're at a surgery last institution where the surgery is the last pillar of treatment and everything else comes before it. And it offers flexibility if patients are coming from out of town. Of course, we accommodate them at any point in time in that continuum, but certainly want to meet them in a timely manner when radiation is going to be needed so that there's no delay in the treatment flow.
So is surgery as the final, is that a very common practice or is that very specific to MCW?
Yeah, unfortunately, at many institutions, surgery is done first. And since, approximately 2009, when Dr. Evans arrived from MD Anderson, that was a common scenario here too. And I think the thought process in reversing treatment makes so much sense. And we'll talk about this more as we meet together today. But pancreas cancer obviously can and is known to be a cancer that spreads early into the bloodstream, through the lymphatics, along nerves. So starting with chemotherapy first makes a lot of sense because the chemotherapy goes everywhere that there's a blood supply and where the tissues are perfused. Surgery is best done in the setting when the surgeon knows that he or she can remove all of the tumor with clear margins. And as we'll talk about a bit later, that's very, very important for prognosis in pancreas cancer to have clear margins. So putting that sequencing with chemotherapy first, then radiation, and then surgery makes a lot of sense and has dramatically improved outcomes here at MCW and beyond.
Awesome. And do you think that in your experience, other hospitals are following suit with that?
I think there are more institutions that are coming on board with that mindset, with publication of data that drives this forward. Obviously, we'd love large-scale clinical trials that would test these questions and show the benefit of this. But our group here, of course, has published quite a bit on total neoadjuvant treatment of pancreas cancer and has moved the bar in survival, almost doubling it.
That's amazing. Well, Dr. Hall, maybe this next question would be good for you. Dr. Erickson talked about pancreas cancer specifically. It's such a unique and deadly cancer. Why is radiation therapy effective?
Yeah, that's a great question. Radiation therapy has been used for decades in the treatment of pancreatic cancer. And what we've understood for the past 20 years of lots of individuals, very, very talented individuals studying pancreatic cancer, is that when patients undergo surgery first, or if patients don't have some type of local treatment like radiation therapy in addition to surgery, treatment just with chemotherapy and surgical resection can result in high rates of local recurrence, meaning the cancer coming back where it originally was. And that can be a very, very difficult situation, both to diagnose, to identify quickly and reliably. And it can also be a very difficult situation to treat when it does in fact happen. So radiation is very helpful in preventing that event because it's a wonderful local treatment that is safe and effective at preventing the cancer from coming back where it originally was. These are relatively infiltrative cancers that tend to track along blood vessels and nerves and spread to the lymph nodes very, very quickly around the cancer. And without something to sterilize the area, like radiation as a local treatment, the cancer can come back frequently. That's one potential benefit of radiation. The other thing that we've understood over the past 10 years is that the environment around a pancreatic tumor, what we call it scientifically as the microenvironment, is almost like a fortress. And it's very difficult for the immune system to penetrate that environment. And it's often very difficult for chemotherapies to penetrate that environment. So in order for a chemotherapy to be effective, which it is very, very effective at treating many different types of cancer, including pancreatic cancer, but in order for it to be very effective, it has to be able to access the tumor and it has to be able to get into the place where the tumor is. And in pancreatic tumors particularly, that is a difficult thing to achieve with chemotherapy because the primary tumor seems to put up barriers and blockades to both recognition by the immune system as well as attack from cytotoxic chemotherapy. So that's another factor that is pretty well understood now in pancreas cancer. Radiation therapy overcomes that in the sense that we're delivering external beam radiation, so invisible X-rays that come from the outside in. We're able to focus that radiation on the area where the tumor is. And oftentimes we can overcome some of those barriers to penetrating the tumor microenvironment that are present with regard to chemotherapy. So we have historically used radiation for those types of reasons theoretically. The third, and I think probably one of the most important rationales for using radiation therapy in pancreas cancer is it gives the patient a window of time before they go to a major operation during which they are not being treated with high-dose systemic chemotherapy. Now, why might that be important? Well, the last thing that you would want to do is take a patient for a major surgical operation, like a Whipple procedure, where the patient is going to have, a week in the hospital. They're going to have, typically a month or more of recovery.
Right.
There is a risk of complications or potential side effects and toxicities from a major operation like that. The last thing you want to do is take that patient for that type of operation if they have a spot of pancreas cancer that has spread somewhere else in their body that's going to grow when they're off of chemotherapy. Okay. Mm-hmm. So radiation therapy introduces a really wonderful option by which patients can have a test of time before surgery in which they're receiving a local treatment that's helping to control their cancer locally. It's helping to prevent local progression and recurrence. It's helping to penetrate the tumor microenvironment, but also gives them an opportunity to be re-imaged before they go on to surgery, meaning you can acquire another set of systemic whole body imaging as another check before they undergo a major operation to make sure that they don't have a progressing area of cancer elsewhere in the body. So those are some of the major reasons why we think radiation is very important, plays a very, very important role for these patients, and why we pretty consistently use it in nearly all stages of non-metastatic pancreas cancer.
And along those same lines, in the historical series with Surgery First, the rate of positive margins is extremely high, probably on the order of 30 to 50%. And the rate of positive lymph node involvement is as high as 30 to 70%. When you add radiation before surgery, those numbers go down to something on the order of 10% for positive margins or less, and 30% or less having positive lymph nodes. And we know that coupled with the tumor marker, the CA19-9 normalizing, that those patients can be patients who have much longer term survival and do better. So radiation in some way translates into improved survival because of those factors.
That's awesome.
So it's both a local treatment, but also improves survival for patients who have those wonderful responses.
And it's not really a one type fits all. I mean, there's quite a few different approaches, right? When it comes to radiation therapy. Maybe you guys want to speak on that?
Yeah, I'll let Dr. Hall talk about one of our important clinical trials preoperatively that he has written and is conducting that addresses that.
Sure. Yeah, happy to do that. So I'm happy you brought that up, because radiation is really a very, very multifaceted type of treatment strategy that we can do all sorts of different types of radiation, from very high dose, what we call ablative radiation that we feel results in significant blockade of local blood vessels and really takes care of any tissue that we direct it towards, all the way down to low dose palliative type radiation that's really intended just to relieve some symptoms and perhaps reduce some amount of tumor, but doesn't really aggressively treat the tumor, and then all in between. So it's really a wide spectrum of options that we can provide patients with. Those are really tailored to the specific anatomy of the patient. They're tailored to the patient's medical history and their particular capacity to tolerate different types of treatment. So those are very complicated decisions that we make as radiation oncologists. But specifically for pancreas cancer, radiation can be given in a variety of ways. So one of the things that we're currently studying is two different ways of giving radiation before surgery. One of them has historically been known as conventionally fractionated radiation given with concurrent chemotherapy. We often refer to it as chemoradiation or concurrent chemoradiation. Okay. And it's sort of it's a type of radiation treatment that's been given for many, many decades. And it gives a small dose of radiation each day. It breaks it up over the course of usually about 5.5 weeks. The patient comes each day, Monday through Friday, and they receive their radiation dose over the course of about 10 to 15 minutes. And that has been done for a very, very long time and has been something that we have historically looked at as a standard for delivering radiation. What we've been able to do more recently is give very high doses of radiation over a very short period of time. And we're able to give what we think is approximately the same biologically effective dose of radiation, meaning the power of this radiation to kill the cancer cells we think is about the same. But we're compressing it over a span of just 5 total treatments. So we've taken the 28 treatments that we historically have given, and we've sort of compressed it down into a period of time of just 5 total treatments.
Wow.
So yeah, so it's a new way of giving the radiation. And at some centers that has become sort of an adopted standard. We have been a little bit, we're very cautious here with how we introduce new things. So the way that we've approached it is we have a randomized trial in which patients that are willing and able to participate in a clinical research protocol are randomly assigned by in this case a computer generated flip of a coin. Essentially, they're randomly assigned to either the 5 treatments of radiation or the 28 treatments, and that will give us what we hope is a true comparison between those 2 treatments. So we're looking at things like quality of life, for example. How do patients tolerate those different types of treatments? We're looking at surgical complications. So how do patients do at the time of surgery? Are there difficulties with operating after 5 doses of radiation versus 28 doses? We're looking at some immune correlates. So how does 5 treatments of radiation interact with the immune system differently than 28 treatments given with concurrent chemotherapy? We think that there are very, very important differences there that the 5 treatments may stimulate certain types of immune cells within a pancreas tumor that are not stimulated with conventionally fractionated daily chemoradiation. So there's all these potentials for differences amongst these 2 treatments that we've been very fortunate to have a lot of patients agree to this randomization. And it's been a trial that's been open here for about just over 3 years, and it's been accruing really well.
That was going to be my question is, where are you on the timeline of the trial? So
yeah, we're about halfway through. Our goal is to, kind of an ambitious goal, but our goal is to put just over 100 patients on the trial. And we are, I believe, just around 50 right now, which is good. I mean, we've been able to do that in the midst of COVID, which, when COVID came, it's something that impacted a lot of clinical trials around the country because we weren't able to enroll too many trials because some staff had to, were working remotely, and it's just been a major barrier for clinical trial enrollment. But it's been actually accruing quite well. Dr. Erickson and I are sort of co-leading it, and she's put a lot of patients on it, and it's been a wonderful, wonderful collaboration.
So the enrollment period is still open then for this trial if someone listening is interested?
Yes, it's still open. We are still enrolling onto it. It will be open for several years. It's a great opportunity for individuals who are interested in participating in a clinical trial. And we kind of go through it with them in a lot of detail with regard to, what the 2 arms are. It's a randomized trial, so there's often some explanations and discussion around that, and yeah, it's still open and available. Awesome.
So I guess maybe you can send me the information, and we can make sure that we have it available for our listeners. A link or some things that they can find the details. Okay, great. And then that's 2 different approaches. Are there more approaches?
Yeah. And, I think the other cohort of patients we see are patients who have disease that cannot be operated on. We call those our locally advanced patients without metastatic disease. And we offer another clinical trial for those patients wherein we give much higher doses of radiation to the tumor and some of the surrounding tissues. And that clinical trial is almost done accruing. That's been slower to accrue just because of the surgical talent that we have on this campus. Dr. Evans, Dr. Tsai, Dr. Christians, Dr. Clark, all wonderful surgeons, and they will tackle operating on many patients who've had preoperative treatment versus surgeons at other institutions. But for those patients in whom surgery is not feasible, we offer this trial. And with dose escalated radiation, we have to be very, very careful because around the pancreas are very vulnerable luminal GI structures, the stomach, the duodenum, loops of small bowel, and large bowel. So we use an image-guided approach, and the genesis of this trial was using MRI rather than just CT to define the tumor. We have some very talented radiologists on our campus who, together with us and our interest in defining tumors better, were able to offer us imaging series during radiation planning in which visualization of the tumor was optimized so that to that tumor, we can give the high dose, but be careful to feather that dose out where the organs, the luminal GI organs live. And that is given, that type of radiation, which is more of the ablative radiation that Dr. Hall was discussing, is given after months and months of chemotherapy. Some of our patients, a minimum of 4 months, but some of them have been on chemotherapy for 6, 9, 12 months and are still eligible to receive the radiation, typically when they're no longer tolerating or responding to the chemotherapy. And even though it's a higher dose, it's very well tolerated because we are careful as to what the GI structures are getting. So the side effects are very, very similar, very able to control them. Patients will take some anti-nausea medicine right before their radiation treatments. We have them on stomach acid medication. And if they develop some heartburn or queasiness, we have some other medicines over the counter that we add. And if need be, we offer support with IV hydration and medications. But for the most part, whether they're dose escalated or preoperative in dose, it's well tolerated.
Wow. And that type of, deep imagery using the CAT scan and the MRI to get that image, do you only use it when you're doing that specific approach?
No. And, one of the tenets of our treatment here at MCW is image-guided. So whether we're using lower doses of radiation, as Dr. Hall discussed, the 28 treatments versus the 5, at a minimum, all patients have CT-based planning and delivery, meaning there's a CAT scan unit built into the linear accelerator that images our patients each day before they're treated. We've extended that, and I'll let Dr. Hall talk about this, to MRI-guided radiation, which uses CT and MRI to define the tumor, and then, MRI before and during their radiation. And I'll let Dr. Hall take it from there.
Yeah. So thanks, Dr. Erickson. MR guidance is something that we as a department have a big research focus on, as well as clinical focus in delivering. And essentially what it involves is, traditionally radiation therapy has been given for the past, say, 20 years or so, or 15 years, with something called CT-based image guidance. And what that means is that before a patient receives their dose of radiation each day, there's often a CT acquired that shows where the tumor is, shows where their normal organs are. And CT is a great imaging modality for certain things, but one thing that it doesn't image really well is soft tissues. And what I mean by that are tissues that don't have a lot of bony structure to them. So tissues that are mostly composed of water or fat cells, or cells that contain lots of water. Okay, so CT is not the best option to take an image of those types of tissues. MRI is, as many people know, is a totally different imaging modality, but it focuses on imaging water molecules. So it's really, really good at imaging soft tissue, things like the intestines and pancreatic tumors and the stomach and the liver and the bile ducts, which are kind of the tubes that come out of the liver. Those are really, really nicely seen using an MRI. The other thing that's really great about MRI is that it does not expose the patient to radiation. So the reason that's helpful is because you can acquire an MRI for a very long period of time. So you can have an MRI imaging a patient almost continuously, and it doesn't require that patient to be exposed to radiation continuously, like, for example, a CT or an X-ray would. Okay. Right. And that's really, really appealing. So what MR-guided radiation has enabled is, in many circumstances, we use this for abdominal tumors, and pancreas cancer has been one that we've used it a lot for, is we can acquire an MRI before we treat a patient with radiation. And that shows us exquisite detail of soft tissue structures, meaning the boundaries between the pancreatic tumor and the intestine, and the precise location of the patient's bowel and intestine and colon and large bowel on a daily basis can be seen with just exquisite clarity using an MRI. So we're able to acquire that image on a daily basis before the patient's treated, which is very, very helpful. We feel that it aligns very nicely. We can see the tumor well most of the time, and we can see the boundaries of the tumor and the bile ducts and things that we historically have not seen very well using CT. And then while the patient is being treated, we can acquire an MRI during the course of their treatment. For most cases, throughout the entirety of their treatment, when the beam is actually turned on, And we can watch the tumor in real time as the beam is turned on and the patient is undergoing treatment. So for example, if the patient's breathing, or if the patient coughs, or if the patient sneezes, or if the patient moves, or if they have a large bolus of air that goes through their intestine, all normal physiological processes that everyone has happened to them, pretty much every day. We can see that and account for that in real time. So we can make very subtle adjustments. We can, watch their tumor. We can watch it with respiration. And so this is a very, very new technology. The ability to do this with a radiation device that we call a linear accelerator that delivers the actual radiation beam is very new. I mean, this is the absolute cutting edge of radiation technology right now, one of them. And so we've not only made a commitment to using this, we're testing it and using it, but we're also studying it in a tremendous amount of detail. So the vast majority of the patients that we treat with this technology go into a very comprehensive international study in which we collect their outcomes, we collect their quality of life, we understand exactly how they're doing, and we're collaborating with universities around the world that have this device to essentially collect a large cohort of these patients that are being treated like this and understand how they do and how their outcomes are in many cases compared to other patients undergoing CT-based radiation therapy.
And this is especially helpful in our patients who are undergoing the SBRT, the 3 to 5 radiation treatments.
Right.
Because when we're delivering that high dose of radiation, we really want to be sure that we're targeting and avoiding things in an optimum manner. And with this technology, while the patient's lying on the table, a new plan is generated each time based on the anatomy of the day. So it allows us this adaptive capability based on their own individual anatomy at that point in time. So our patients who get the 5 treatments, if they're able to handle being in an MR-Linac, will get treated on the MR-Linac. And some of our non-soft patients, Dr. Hall's protocol, will also go on this unit if they have locally advanced disease that for which surgery is not possible. So it really offers us another fantastic tool to help patients with inoperable pancreas cancer.
Yeah, giving you that kind of up to the minute information.
Yes.
Very cool.
Yes.
So I know we've talked a lot about different approaches and we kind of have touched on this, but could you walk a patient through what radiation therapy would look like for them? Just maybe an overall
Sure.
snapshot.
So maybe I'll do the simulation, Bill, and do you want to do the treatment? So when patients come in for their planning session, we call that a simulation. And typically they'll stop in the lab first to get a blood test to make sure that their kidneys can handle the CAT scan dye that we use. They'll have their port accessed or an IV placed. Then they'll come to our clinic. They'll meet with us in a room to review the planning process, which essentially involves going into a room with a unit that looks just like a CAT scan unit they'd see in radiology. They'll lay on the table and have a mold created around them out of like a beanbag material that helps to keep their body straight because accuracy is so important, but it's not real confining. Then they will go through a series of CT scans, one with and without the intravenous contrast. We have them drink a little bit of dye to see their stomach and their duodenum and small bowel. And we do a scan that also assesses how much their abdominal contents move while they breathe. We call that a 4D planning CT. And it helps us to assess for motion in the upper abdomen, influenced by your diaphragms, your peristalsis, all of those normal activities. That set of scans can sometimes be followed by what's called an MRI simulation, where they go next door and lay on an MRI table and have a series of scans that are used. And we like to do this a lot when we're doing dose escalation. We'll get that MRI scan following the CT scan. And that's our planning day. Patients go home from that. They spend about 2 hours with us to do planning. And I'll let Dr. Hall take over for the actual treatment.
Sure. So after the planning session, the CT and the MRI, there's a whole process that takes place behind the scenes, and it usually takes at least 1 to 2 weeks for us to generate a customized radiation plan for each individual patient, and that is really a team approach in which we have a number of individuals involved with creating this extremely sophisticated, complicated dose of radiation that's going to be delivered precisely to that patient's anatomy. And it's going to be adjusted based on the locations of their normal organs and the precise location of their tumor in any regions that we feel are at risk for having microscopic cancer cells. So once that process is completed, a patient will usually come in for their first day of treatment. Now, on the first day of treatment, there's a lot of things that need to take place to confirm that the patient lines up correctly and that the patient's radiation treatment plan and their normal organ position is similar to the way it was when we originally did their CT mapping session that was done usually 1 to 2 weeks prior.
Okay.
So typically a patient comes in, they meet with an individual known as a radiation therapist who will typically bring them back to the machine on which they will be treated, which is called a linear accelerator. They are then positioned, usually they'll change into a gown. They are then positioned on the linear accelerator using a couple different strategies. Sometimes we will use a laser positioning system where there'll be red or green laser beams that will come from the walls that will align the patient with some marks that are put on their skin at the time of the CT simulation. They're usually stickers that we use to align the patient on a daily basis. Sometimes we use other technologies to align them and make sure that they're in the exact position that they were during the CT mapping session. And then after that, typically the therapist will step out of the radiation treatment room and an image will be taken of the patient on a daily basis. So we'll go ahead and acquire another image, either a CT or an MR-based image, depending on the technology that's being used to treat them. And then the radiation oncologist that designed their treatment plan and that knows the case and originally saw them in consultation and is sort of leading the treatment team and leading the treatment recommendations for that individual patient will be called to review the images that were acquired that day and will be called to review and scroll through the normal anatomy and how it's changed or moved in any ways and approve the delivery of radiation for that treatment. And so that first day can be a little bit longer. And sometimes patients have that first day and they think, oh, this is a longer process each day than potentially I was anticipating. But we usually like to inform and educate patients that the first day is kind of the longest day. It's really the day, the setup that involves a lot of images and a lot more measurements than are typically acquired on a daily basis.
When you say longer day, you mean like a half of a day or?
No, it's usually probably anywhere from 30 minutes on the shortest end to maybe an hour and a half on the longer end, really depending on how they set up and depending on how their particular treatment is being given.
Okay.
And then once everything's approved, everything is looking great, the radiation beam will turn on. And what we tell patients is you don't see or feel anything, and that's very true. It's invisible X-rays that you do not see or feel. And their only job is to lie nice and still and just to let the therapists or the team know if they're having any problems. So if they're uncomfortable or if some patients have claustrophobia, they get afraid of small spaces, all normal things. We watch the patients very, very closely with both a video monitoring as well as an audio monitoring. So if any concerns arise during their treatment, we can stop the treatment and come in right away. But basically the beam turns on, the patient will hear the machine delivering the radiation. They'll often see this treatment machine moving around them, and they'll see a large machine that kind of goes around their body. in some cases, or they will, if they're in a device that doesn't have a moving arm, they'll just sort of hear the machine going around them. And then usually the treatment lasts for anywhere from, maybe 10 to some cases 20 or 30 minutes, depending on how it's being given. Some cases longer if we're doing SBRT or high doses of radiation for treatment. After that period of time, the patient's done. They can come off the table and they go home. There's typically no anesthesia. There's not typically an IV. I always tell patients there's no cutting. There isn't any real issues on the day of. We usually have them take some medications before the treatment with the goal of preventing any side effects. So this is something that we go over with them at the time of their original CT mapping session. But we typically will have them take like an anti-nausea medication before they get on the treatment table. We usually, for pancreatic patients, we ask them not to eat anything about 4 hours before they're treated. And that it helps to ensure that the stomach is empty and the intestines are empty close by the pancreas tumor. Mm-hmm. And typically we have them take a medication that suppresses their stomach acid a little bit, just to try to prevent any irritation or reflux or things like that during the course of treatment. But aside from that, it's a relatively easy treatment. And then during the course of treatment, they have a very, very close relationship with their radiation oncologist. So I usually tell patients you're going to see a lot of your radiation oncologists. You're going to see them. We typically see them every week. We check in with them a minimum of once a week, oftentimes more. And that usually just involves vital signs. We check their blood pressure, their heart rate, their oxygen saturation, their pulse, those sorts of things. We check their labs. We make sure that their blood counts are remaining within limits that we want them to be. And we ask them how they're feeling. We do a physical exam, and any symptoms that come up, we address those during treatment. So there's a comprehensive medical care for that patient during the course of their treatment, with incredibly close attention from a medical doctor who's a radiation oncologist during the entire course of their treatment.
So you become their new best friend.
Yeah. And our team.
Yeah, and we have
nurses, nurse practitioners. They grow very fond of the therapists who are treating them every day. Mm-hmm. This is this wonderful army of healthcare workers who surround them when they come to radiation oncology. And for many patients, it becomes their second home for that period of time.
And you talked about, for pancreatic cancer specifics, that they need to fast 4 hours before. Are they allowed to drink water or things like that, or is that not recommended?
Not too much.
Yeah, usually it depends. It depends on the individual patient. We do have some flexibility in different cases. Some patients have a lot of issues with diabetes or blood sugar, or they need to take medications at certain times throughout the course of the day. So these are really tailored recommendations. It's not like a one size fits all, but most of the time we encourage them, if at all possible, to try and not, eat or drink a lot. Sometimes I'm okay with some, sips of water or juice or that sort of thing. If people need to take medications, or they're very thirsty or diabetic, or those sorts of things are very understandable. But usually we ask them not to eat too much or drink too much before their treatment.
Okay. The rest of the time, though, we want them to eat and drink, because it's very important that they not lose a lot of weight during their treatment. And likewise, we don't want them to gain a lot of weight because based on their body mass, if it changes significantly, they may need to undergo replanning. So that's important, and we monitor that very carefully.
Okay, and then that kind of leads into my next question about symptoms. I know you touched on nausea. Are there other symptoms?
Can have some near the end of treatment, kind of a gnawing, empty stomach feeling that can be due to some irritation of the end of the stomach or the duodenum. And then we'll have patients supplement that with some liquid antacid. One of the kinds that we like to use is one called Gaviscon liquid. It just helps to coat those luminal GI structures. The other thing is fatigue, which can be progressive over the weeks, but typically not debilitating.
Okay. And is weight loss or gain usually associated, or that really just depends on the patient?
It really depends. With pancreas cancer, oftentimes patients lose their appetite, and we really encourage frequent small meals, high calorie snacks to try and combat having to sit down and eat a big portion of food, which oftentimes people are unable to do. And they will see a nutritionist every week during their radiation, just like they would during chemotherapy. And they're very helpful in recommending supplements and other things to help ease weight loss.
Okay. So why wouldn't a patient choose radiation? Like, are there other risks associated?
Well, I think, people hear things about radiation that from friends and family members sometimes that are really perhaps not based in reality. And one of the concerns always is fear of complications. With modern radiation, this has really been very much curtailed. And we would say that the risk of a complication following radiation to the upper abdomen is exceedingly low, less than a 5% chance of rare ulcers or bleeding from the upper GI tract, which lives near the tumor. But other than that, extremely rare to have complications.
And it's worth mentioning as well that, I often like to tell patients that we're really trying to understand the best way to treat pancreas cancer. And the reality is we don't know. And that's why we're doing a lot of research, and we're really trying to study it and understand what the best way to treat it is. Some institutions and some centers around the country, they don't routinely recommend radiation for pancreas cancer. That is not something that we do here. Many institutions routinely use radiation like we do, but some don't. And so that can often be confusing for patients. They may hear, well, they're in very supportive online communities, or they reach out to, foundations like your own, and they hear from other patients around the country, and they may hear that, well, this patient didn't receive radiation. That can often be confusing. And I usually like to highlight to patients that there are many reasons why we kind of started this at the beginning of the discussion. There are many reasons why we think radiation is extremely important. But it's important to know that some centers don't share that sentiment, and some centers have not historically offered or used radiation routinely for patients with pancreas cancer. So that may be another reason why patients are not receiving radiation.
And what do you tell patients when they come to you with concerns like that to encourage them?
Yeah, the reality is that the vast majority of patients, when you explain this to them in sort of a basic and non-technically complex manner, they understand exactly what we're rationalizing and why we often feel that radiation is so important. And I usually just explain to them the difficulty of treating this cancer, and the fact that unfortunately pancreatic cancer is one of the most deadly cancers that exists. And when you have a cancer that is this deadly, that it really benefits from an aggressive treatment approach. And we feel that the best way to cure this cancer, which we can do, and we do, routinely here, the best way to cure it is with a multi-modality aggressive treatment approach that involves chemotherapy, radiation therapy, and surgery, usually given in that order. And I just explain to patients that when patients don't receive radiation treatments, the rates of the cancer either being left behind at the time of surgery or the cancer coming back after surgery are very, very high. And that's a very difficult circumstance. I also try to explain to patients that a lot of people, like Dr. Erickson was saying, have complete misconceptions about radiation. They think that it's a toxic treatment that's going to be difficult to tolerate, that they are not going to successfully complete their radiation, which is absolutely not true. With modern era radiation, with specialized radiation oncologists that focus on this type of cancer, we less than probably 10% of the time, or maybe even less, we have patients not complete their treatment, meaning the vast majority of patients successfully complete their treatment. the vast majority of our patients are never admitted to the hospital during their treatment. So they are outpatients, and we have very streamlined approaches to keep them out of the hospital. And the reality is it's very, very well tolerated. And so I think that that I usually tell them that as well. And most of the time, patients are very, very receptive to that rationale. Dr. Erickson, what are your thoughts about that?
Yeah. And in addition, our surgeons would be resident, to operate on these patients without radiation. They really see the benefits of preoperative irradiation, both in the procedure itself, because it firms up the remaining pancreas and makes it much less likely that patients are going to have a pancreatic leak. Mm. And they also know that the margin positivity and node positivity rate goes way down, which translates into improved survival. So you'd really have to twist the arms of our talented surgeons to leave radiation off the table.
Okay. Well, I know we talked a lot about the clinical trials and research that's happening there at MCW. What are some other future developments that you guys are seeing in your field that are looking exciting, or new research that you're excited about?
Dr. Hall can take this one.
I'm happy to take that. Yeah. So I definitely have a real passion for cancer research, particularly surrounding radiation oncology and radiation therapy. So we are in a tremendously exciting time for the delivery of radiation. I think probably the most exciting time that we have encountered thus far as a specialty. And there are multiple things that are contributing to that, and multiple areas that are really, really exciting to me as a cancer researcher and as a radiation oncologist. The first is the ability to know exactly where and how radiation is being delivered through real-time adaptive MR-guided radiation. And we were touching on that a little bit earlier, but we are just beginning to understand how well and how accurately we can deliver radiation through this idea of real-time adaptive image guidance. And what that means is that when a patient comes in to receive their radiation, we're able to tailor and adjust the dose of radiation and the distribution of that radiation dose based on millimeter differences in their normal organs. So these are just incredible capacities, incredible capabilities that have only really been introduced in the past 2 to 3 years. And we've just been starting to learn how to optimally use them. So that is a very, very exciting area that will only get better. And it will enable us to give more accurate and higher doses of radiation to exactly where it needs to go in manners that we have never been able to do before. And this will truly reinvent what our thoughts are and our capabilities are with radiation. I have a lot of confidence that will happen in the next 5 years. The other thing that's so exciting is computational power and artificial intelligence and neural networks and imaging are revolutionizing what you can do with a computer-based environment. Okay, so your ability to acquire an image, a very, very detailed anatomic image of like an MRI, mm-hmm. and then understand exactly where the tumor is and exactly where the normal organs are in a moment's time is exponentially increasing. Okay, so what we will be able to do in 5 years using sophisticated computational image processing is going to be magnitudes more than what we can do now. As radiation oncologists, we dramatically benefit from that. Okay. So other oncologic specialties don't have anywhere near the magnitude of improvement in their modality that we have with computational advancements. So, for example, surgical specialties, the surgical procedure is largely still going to be done the same way, right? It's going to be the same organs being resected, the same type of approaches, maybe some subtle variations to it. Chemotherapy is going to be administered the same way. It's still an intravenous therapy that goes through the bloodstream. So they'll maybe be helped a little bit because the tumor can be imaged better and they can see perhaps a little bit better. But our modality of radiation is dramatically transformed by that because we can incorporate information and data in real time using artificial intelligence or using advanced image processing that we weren't ever able to do before. And that's going to significantly change our radiation capabilities. That's one area that I think is very exciting and rapidly changing. The other area that to me is so exciting is the concept of giving different dose rates of radiation. And let me explain what I mean by that. So historically, radiation was given at a certain rate, meaning you would deliver a dose of radiation over a particular time, say 5 minutes, okay? And that's the way that radiation has been given for decades. That's the way the machines are designed. That's the way that radiation is typically administered. Very, very recently, it's been discovered at other institutions outside of MCW, some centers in Europe, as well as some centers in the United States have been working on a concept of delivering the radiation much, 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 much faster than it has historically been given. What's fascinating about that is it not only speeds up the treatment, which maybe adds a little bit of convenience, but it seems that biologically at the level of a tumor and normal organs, the dose of radiation has different effects, and that it seems to be more effective potentially on tumor cells than it is on normal tissues. This is largely being done in animal models right now. So this is not really a prime time treatment. But it's a very, very exciting area of treatment because there's a couple of reasons it's so exciting. First is that we don't truly understand biologically why we're seeing these differences. Mm-hmm. And that introduces an opportunity for a major discovery with regard to how radiation is killing cancer cells. Because when you're observing something in a laboratory or a preclinical setting that you can't really explain, you don't really understand, there's usually an important mechanism or an important underlying biological finding that needs to be brought out of that situation. So that will likely take place in the next 5 years. And I think that could have dramatic benefits for patients potentially getting treated with radiation in the distant future, not in the imminent treatments, but in the distant future. And then the third thing that excites me is chemotherapy is getting better and better and better. And the reason that's so helpful is because tragically, many patients with pancreatic cancer develop distant metastases, meaning the cancer spreads elsewhere throughout their body. Right. And if we don't have effective ways to address that, radiation is never going to be able to meaningfully impact patients. So as chemotherapy gets better and better, the importance of treating the primary tumor with an effective treatment like radiation therapy or surgery, or both combined, becomes increasingly important. So I think the future is very, very bright, and we have lots of reasons to remain optimistic. Research is critical to this. We have to study and understand the best way to treat these patients. The only way to do that is through well-designed, conducted clinical research. And so, yeah, for those reasons, I think we're very optimistic and excited.
Yeah, I mean, and things have changed so much, just within the past 10 years. And Dr. Erickson, I mean, in your 30 years of experience, how does it make you feel thinking about these advances within the next 5 years?
Yeah, it makes me sit on the edge of my seat. And I've been there throughout my career. And I think we as radiation oncologists are so fortunate to have this incredible technology that we can bring to our patients in a very personal way. And truly is a delight to do what we do. Not that patients have cancer, but that we can help them on their journey through it and beyond with wonderful tools and a wonderful team.
And here at the foundation, I mean, we're so passionate and committed to providing funding for these type of research and innovation. So it's exciting to hear all of this. Is there anything that I missed? Anything that you wanted to add?
I don't know that I have anything more other than that we're here to help whoever comes our way and along their journey. Very, very happy to be contacted or see them in person. So we've got a great team here.
Yeah, I would second that. I think that what I usually emphasize to patients or family members or friends or anyone that ever asks advice is that the most important thing that you can do as a patient or as a family member is ensure that you are being treated in a center that has a lot of experience. And for pancreatic cancer, that is, I think, by far one of the most important things. And so finding a team, and it should always be a team. It's never one individual. I always tell patients this is a team approach. We practice as a group, and we have a group of experts. It's never one person dictating how things are going. But patients really need it. Patients with this devastating cancer really need a team, and a team that they feel comfortable with, and a team that's going to explain to them exactly how they're going to approach their cancer, what the plan is, what the next steps are, and a team that's going to get them through any possible complication or hiccup or issue that arises along the way. So that is very, very important. And I would second Dr. Erickson's comments. We have a wonderful team here, and I truly think it's one of the best in the world, and that we're always willing to see patients, discuss cases with patients. Second opinions are something that we do often. We do those virtually, we do them in person, and we're happy to do that anytime.
And we continue to push the envelope. We really value research and moving the bar. It's never enough.
Absolutely.
Agreed. And we won't stop until we get there and find a cure.
Yeah,
That's right.
Well, thank you so much, Dr. Hall, Dr. Erickson. We appreciate you being here, and hopefully we'll have you again on the podcast soon. And we're here for you guys as well if there's any way that we can help. So,
thank you.
That's great. Thank you so much.
Yes.
And thank you everyone for listening. We hope you enjoyed this episode. If you haven't yet, please like and subscribe. And if you enjoyed it and want to share it with a friend, we encourage you to do that as well. And if you want to find out how you can get involved in the fight against pancreatic cancer, you can visit our website, sinamagwitzfoundation.org.